Children's Hospital and will be presented by Dr. Mohammed.
أنا بدأت في الجيل يا أخوان.
And we are honored to have Dr. Ahmed with us, Assistant Professor, Associate Professor of Nephrology, and he is one of the Vice Director here of the hospital.
It's a privilege for me to be here and present my case in front of all my new professors. And it's not the only case with this current problem. Actually, our data in the Cunningham serves over 40 cases of children who are on regular hemodialysis. And actually, they are being so long on hemodialysis because they are not eligible for transplantation for lack of methadone. First, we will give a brief hint about the cause of which led to this case to be a CKD, and a brief lines about our management of the case, and get a little jump to the current problem in this case. Our brief history, we have our patient age of 10 years. He presented to us by history of upper respiratory tract infection, followed 10 days later by puffy eyelid, lower limb edema, headache, dark colored urine, oliguria, and urea. There was no purpura, other artificial bleeding, no history of arthritis or manifestation of other systemic infections. By examination of this child in the emergency department, his work parameters were not at the age of 6. There was a mild degree of pallor, edema lower limb. Blood pressure was highly elevated, 190 over 120, which is an hypertensive emergency. He was tachypneic and tachycardic, otherwise normal examination. So we rapidly go into check the end organ damage of this hypertensive emergency, and we done on this examination, which was normal, and we done echocardiography, which revealed mild dilatation of left ventricle. Of course, we have already renal. Our laboratory investigation revealed proteinuria and hematuria in our urine analysis, and dysmorphic RBCs and face contrast microscope examination. Serum creatinine was high, electrolytes were normal, calcium is slightly bit low, phosphorus and pH normal, and serum albumin was normal. ABG showed metabolic acidosis. CBC showed microcytic hypothalamic anemia, which was revealed by iron kinetics. Serum citrate was low, ASO was elevated, and a double strand and anchor were negative. So proceed to radiological evaluation. The ultrasound showed that both kidneys were normal in size, show increased parenchymal epigenicity with good particular differentiation, actually grade 2 nephropathy. So at this stage, the question arises. What is the clinical diagnosis in this case, and what is the emergent therapy that I need to give to salvage this kidney? So my case is a case of rapid progressive pulmonary arthritis, and what I expect to be the next step.
So this is your first question?
Yes.
First thing I want to say is that you're asking an adult pathologist to tell you, the pediatricians, how to look after a pediatric case. So just keep that in mind. The experts are over there rather than here. But things that strike me here, this kid is obviously very sick indeed. You have what looks like an acute nephritic syndrome, would be the old terminology for it, with high blood pressure, very high blood pressure indeed, serious renal impairment, very active urine, and I didn't see a chest x-ray, but I'm presuming that this patient was probably pulmonary edema as well. Is that correct, because of the tachypnea?
Yes.
And the following expansion. So this is a real emergency, and the question is, I mean, I presume it's still the case that if you are confident that you're looking at a conventional post-infectious acute pulmonary arthritis, you would often take a conservative view as far as activity everywhere. And the things that would worry you a lot. Did you tell me what the platelet count was, by the way, not the blood film? Right?
The blood count?
Blood film and the platelet count.
And it's blood count?
Both, they were normal. So just anemic. And, okay, so we're no fragmented cells.
No.
Nothing to suggest HOS or anything like that. TNA. No. Okay, which would, without that would be very much on the important differential levels. Where HOS is definitely something that can present this way. So I'd be worried about that, but I think that's largely excluded by the blood film being so good. Interesting that there are no fragmented cells despite the very high blood pressure. And I know that in a 10-year-old child with a blood pressure this high, it's very likely that you will go into the accelerated phase of hypertension. Partly because of the age. An adult less likely, but a child will be quite likely. So linked hypertension. So my question is, what do the optic fungi look like?
Because
Final presentation from this examination was
Normal.
Yes.
Okay. Well, I'd say that's potentially a good sign in that it suggests, first of all, hypertension is probably a recent onset. But secondly, that the patient does not appear to be in the accelerated effect of hypertension, which is potentially something. But we have a major renal syndrome here, and you need a diagnosis, don't you? So, what investigations are we going to do? What's the next key investigation? Anyone care to offer? I guess I'd better address these questions to the younger doctors in training. So, would anyone like to, the younger doctors here, like to suggest what the next move should be? Pardon? I think so. I think we need to answer pretty quickly here, don't we? We are nephrologists, we do biopsies. So, okay, tell us. We had a biopsy. Did we have a biopsy? Yes.
Yes, we already had the biopsy, and actually in no time, approximately within 1 or 2 days after the presentation of our case, it was the decision to take a biopsy, and it was done by our eminent pathologist, Cunningham. These are the actual pictures of pathology here to our child, and this picture shows that I have 3 glomeruli, and most of them show crescents.
There are 5 glomeruli. Yes. 1, 2, 3, 4, 5.
Okay, so this is a nasty looking biopsy. Just let me see the interstitium. Can I see the okay. So there's a lot of interstitial damage here as well, actually.
Yes,
so the tubals are quite atrophic.
yeah.
Even on this stage, you can see that.
And this, I think all these are plasmacytoid cells. Yes.
So how long do we think this process has been going on in the biopsy? Do we think this is a real acute process, or do we think this has been going on for a while?
Can we just to continue the other?
Okay, sure. Okay.
Here also percent, which is formed by quality stain and silver stain. And here by mesenteric stain, and now actually is hyperspecific, which means that this process has been long going on, and have had a little bit of time to save the rest of the glomeruli from being killed.
A nice question here, sir. About are we dealing with a chronic problem, or this is actually a acute injury because of presence of both of them, cellular crescent and fibrous crescent? So this is I diagnosis. How can we deal with this case?
I think. Well, what do we think? What's the view in the audience here? Do we think this is mainly chronic, or mainly acute, or a combination?
Usually,
I'd agree.
wanted to use combinations, acute and chronic element. So I treat the patient. I should treat because to say chronic kidney disease in the other of the program is supposed to be months. So
I'm not so much thinking about CKD as I'm thinking more about how long has this process been going on, and is it still very active or not? And to me, this looks as though it's been going on for quite a while, but it also looks very active as well.
Yes.
So there's plenty to go for if we're going to try and treat this.
exactly, we have clinical and pathological activity. Here, fluoride clinical activity in the form of acronephritis with renal failure, creatinine 6, something like that. So I think we should strive to treat the patient unless there's contraindication before they go somewhere.
We'd like to know how we're going to treat the patient, and then we've been helped in that by knowing a bit about the immuno studies.
Immunofluorescence and serology.
Immunofluorescence or immunochemistry.
We did this. And there's our approach for this case, which is carcinogenic or nephritis. We did immunofluorescence. And we have a granular immune complex deposit with SS3 level, small subset of the B post-infection nephritis with beta-4.
So what are the immune deposits in this patient?
You have immunofluorescence for this case?
Actually, this case was diagnosed about 5 to 6 years ago.
Yeah.
At this time, we are now using a routine immunofluorescence.
But at that time, there was no immunofluorescence.
To be realistic, we don't have immunofluorescence.
All right.
This is our algorithm for dealing with acrocentric glomerulonephritis.
Okay. Right. So that was what you were operating on when you. Yeah.
So here you put the algorithm, starting with the immunofluorescence microscope.
So there is lymphocyte, there is cellular graph, there is proteinuria, there is kidney burden.
You know, I mean, when you look at the now, you will mention what immunofluorescence.
Yes, sure.
Sure. But
This
in
is
the
around
case,
2 years ago.
there was no immunofluorescence. Because there was no immunofluorescence in your case, and I strive to have all serology for infection, for lupus, for meningitis, etc., and I treat the patient anyway.
Yes.
Did your pathologist think there was any necrotizing polyangiitis in these glomeruli?
There's no criteria, clinical or laboratory, to support this at the level because most of the serology comes negative.
Yeah.
There is no clinical clue for this.
And no vasculitis condition.
No vasculitis. No clinical.
And the lupus serology was all negative.
There.
Yeah. So what do you think? What do you actually think is the underlying diagnosis here?
So at that level, we call post-infectious is the most common cause of this our locality.
Yeah.
There is actually positive evidence by hypochondroplasia, ASO positive.
Yeah.
But what makes us like wary is this is not common presentation. It's not common to see the cases with RBGN. Like all these fibrous percent just about 1 week from time of presentation of clinical presentation. So this is query for us.
We have here in this center a very nice study published since 10 years or more by Amr Hussein Ital. And this study was post-infectious concentric glomerulitis. So we have more than 20 cases, and the majority of them were
So what's the percentage of the cases that come through this RBGN? About 3%, 5%?
all of them are concentric.
All of them?
Post-infectious concentric. This is the
This is not.
and I can forward to you this article because it's very important and it gives some ideas about correlations and protection.
Sure, but Dr. Hussein, this is not the case with us now. Because we see a lot of cases with normal, about 90% of them are resoluting
So your question, I want you to crystallize the question now.
Yes.
What the question to the expert?
So we are not reaching the question yet.
Okay, so
just introduce the etiology of the individual disease.
Okay.
Because it's not.
Go ahead.
Okay.
Go ahead, please.
Okay, then we were a critical case and the management was symptomatic for the metabolic derangement. And we proceeded to dialysis because of the anuria and colon overload. And then we started the immunosuppressive and anti-inflammatory. This is our protocol management of RBGN in our unit. Started by 6 pulse of 5 breath, followed by oral prednisolone for 1 month, and this started oral steroid over 5 months. Second line here is cyclophosphamide to stop the version of changes. Unfortunately.
So it's once monthly, IV cycles.
Yes.
For how long?
6 to
6 months.
So you give that to all patients. You said second line. You've been through the patient at the beginning, correct? Yeah. Sounds reasonable to me.
Unfortunately, our patient didn't show any improvement regarding clinical lab, and after 3 months of continuous dialysis in our unit, was diagnosed with a case of end-stage renal disease. Of course, it was a need for renal transplantation, which was delayed from the flag of mentioned. The laboratory investigation that was done at the time showing rising creatinine, low serum calcium, slightly elevated serum phosphorus, normal pH, slightly low serum albumin, and show mild metabolic acidosis and diabetes, and also CBC reveals macrocytic hyperchromic anemia. So we give him the chemotherapy, which is in the form of, we treated the anemia by erythropoietin and by iron. We prescribe calcium carbonate and sodium recur for the acidosis and the antihypertensive therapy in the form of mineral epilet, and we started the bovate and folic acid and licarotene.
Why licarotene?
Because most of our patients have low levels.
Do you measure the licarotene?
Not licarotene, but other stuff. Not licarotene.
Any evidence that replacement doesn't any good?
I'm not sure because it's a very small number of cases compared to the we assume that we need to give them antidepressants because we have like symptoms of diabetes deficiency. We have a lot of problems with types like cramps, like neuro sinus manifestations and so on. So we do some relation about this.
Just make the point because it's conventional in adult pathology to give water-soluble multivitamin supplements. To my knowledge, there is no study that shows that giving those vitamins makes any difference to outcomes, except in a very small number of specific deficiency scenarios. The only one I've been involved in studying myself is folate. Many, many years ago, we did a study looking at randomized essentially the whole dialysis population in our centre to try to get supplementary folic acid or not. Finding that none of them have been getting it. There was no change in hemoglobin concentration, no change in red cell indices, massive change in serum and red cell folate levels, of course. So we concluded that folate was irrelevant, even though the levels were fairly low. So I suspect the same may be true for some of the other more soluble disorders.
As you said, sir, too, in pediatrics, there is no evidence-based data regarding this.
Good. So we're then on a standard sort of maintenance dialysis schedule here. Just one question quickly. We have talked about the urgency of making a clinical and pathological diagnosis here, where we're trying to dictate early initiation of treatment. And it's still, even though the treatment clearly didn't work, all phones off anyway. Sorry about that. So there's clearly a big focus on making a diagnosis, clinical and pathological diagnosis quickly, but what we didn't talk about was the urgent management of what was about to kill the patient, namely hypertension and pulmonary edema and volume expansion. That was what was the threat in the immediate sense of patients. So how does that happen?
Actually, by hemodialysis.
Okay, so you did emergency hemodialysis?
Yes.
You didn't try any non-dialytic?
No, because it was an emergent condition. It was anuric and was uploaded in emergency.
The patient was anuric at that stage?
Yes.
Never passed urine since, is that right? Or gone?
Anuric from the start. This may be the cause of this very high level of blood pressure.
Yeah.
Combined with vascular and volume.
I think so. Well, anuria in that scenario is a very bad prognostic factor, of course. Was there any case to be made in retrospect for not immune suppressing the patient, given the fact that the presentation as it was with anuria? It was always going to be quite unlikely that you would get a good response. The patient did then end up having a lot of steroids and cyclophosphamide at the age of 10. I'm just being what we call devil's advocate here. Do you think in retrospect that was the best thing to have done or not?
I think we started late.
Oh, yeah.
There is late when we started dialysis.
Yes.
You started it early, but the patient
Yes,
came to you
the
later.
management of this case started from the ER because the patients come to us, I think, late. Type of presentation, there's anemia, blood overload, high blood pressure. So we start to do all the medications and all lines of management at the same time. Dialysis, side prednisone, and we did all this lab that comes to you. But at this time, we actually have a lot of fibrous percent there. So I think this is the cause of resistance of improvement of the clinical stage regarding use all your equipment at the same time.
So the patients and uric time is very late, and the cardiovascular sense, the must some to know about the
When you see the case in the
there is a curious pathology that chopped the kidney anyway. So I want you to go straight for the question, no question of the case.
Okay.
Because of the time. So we give the pediatric case this time because Dr. Ahmed told me that he has 3 cases, but he's summarizing in 1 case, so it's okay.
So this is the time of 3 cases.
Yes.
Yes. Thank you.
Our patient was managed according to the pediatric guideline for chronic kidney disease. You will see we have our child in stage 5, where GFR is below 15. I check the calcium phosphorus every month and the PTH every 2 months. The dialysis session prescription, which we were trying to make it as optimum as possible, was regular dialysis 3 times per week. He had the IV fistula sessions for 4 hours, filter 55 high flex membrane, pump rate 200 after glucose system, and reaching the optimal KT/V monthly. Meanwhile, it was about 21. So here our problem started. 1 year ago, he started to suffer from hypoparathyroidism. Our PTH here is elevated, 725. Calcium is normal, phosphorus is elevated.
Big PTH or the...
No.
So let me just ask a question of the audience quickly, sorry to interrupt you. What do you think is the main driver to the hyperparathyroidism here? Hyperphosphatemia.
Yes.
The obvious thing here, isn't it? And we're talking about a child, and my guess is, I know adolescents controlling phosphate is very difficult because they don't like it. I imagine a 10-year-old child is no different. That you have a real problem, I would think, in pediatrics, trying to maintain good phosphate control. Whatever you try to do, ultimately you're going to be dependent on the patient adhering in some way. And I don't know whether this is a boy or a girl.
Because we have difficulties in those age group patients, because they are usually resist the nutritional instructions to them. This is the main cause, because they take a lot of phosphate in their diet, in spite of the resistant instructions to come stuff that we need to eat like this. We have food plans and diets of them. But as you see, there is persistent hyperphosphatemia in spite of all measures regarding phosphate binders, regarding nutritional management, and also using the local sensitivity diet and so on. So this all the guidelines say this. But we have a lot of problems in this case outside the guidelines. So the guidelines say you do blah blah blah, and we did it without a reflection of the case. We have a lot of cases like this, not only this case.
Or whether the treatment you give reflects what the guidelines say. Yeah. You're saying that this patient probably needed slightly different treatment.
Yes.
Okay. Here's a very important point of discussion. Carry on talk about.
Because that's what we explain the guidelines now, and what we give to this patient to treat this very high level of PTH, sky high, and how to increase the phosphorus level.
Okay, according to this stage right now, by this step, the guideline and we try to target the serum phosphorus level as for children with kidney failure, stage 5, restricted with hemodialysis. The serum level of phosphorus should be maintained between 3.5 and 5.5 milligram per deciliter during adolescence, and between 4 to 6 milligram per deciliter for children between age 1 to 12 years. This table shows the normal value for serum phosphorus in calcium and blood ionized calcium. according to the age. And our child here now, he is now a 6-year-old male adolescent. So I have serum phosphorus to be targeted between 2.3 and 4.5. So we started Renagel, and the calcium trial was stopped, and we tried to control the diet phosphorus, which was decreased to the dietary reference intake per age. This algorithm here show the guidelines that we are moving on. We measure serum calcium here, so our calcium is more than 10.2. So we stop the vitamin D therapy, and then we have a serum pH, which is more than 300. So the option is to change to less calcium vitamin D serum. Also with serum phosphorus, which is more than 6. So I hold vitamin D and measure after 1 month serum phosphorus again. If it's not less than 5.5, I should increase the NK, the phosphate level. Okay, here this I can show our measurement with serum pH. I want to check the lowest at the bottom of the page. When my input pH is persistently high, which is similar to this case, and the phosphorus is high also, and the calcium is around is approaching the normal, then we have a trial with this calcium and the low may be good. The follow-up report revealed persistent elevated pH 875, calcium approaching normal, phosphorus beginning to be normal. The follow-up after 1 month, persistently elevated serum pH exceeding 100.
What's application of the guidelines? Persistent application of these tips and guidelines. You still have
throughout the previous 6 months, it's likely like this with elevated pH, and phosphorus of the elevated, then come to a normal level, and then it become elevated again. So we started silic acid with this patient over the last 4 months, and we tried to look for parathyroid adenoma. Renal ultrasound, of course, is greater than nephropathy, and there was a parathyroid scan, there was absence of parathyroid adenoma. This show plain X-ray for the hand and the skull and spine of the patient. Of course, we missed the lateral view, but it was normal. So, in spite of 4-hour effort, please check with the patient regarding the dialysis prescription or the diabetic measures or the other medication that we give according to our guidelines. I still have 2 major problems: the persistently elevated serum phosphorus and pH, and of course the clinically continuous recurrence, which is a bit disturbing for this patient. So the question is, should I go proceeding to parathyroidectomy, or there another else to be done as medical treatment for this patient?
How much is selective into the patient? How much is selective?
I give him
What dose?
The dose.
the dose 1 tablet per day.
You start at 30. Then you go up.
Then I go up.
6 months. You did 6 months.
Okay, and what dose?
30.
Just 30. So you stayed at 30. So you stayed that's a low dose.
So we doubled it to 60.
Yeah, okay.
And still, after doubling to 60, the pH is
The
increasing.
last one is double the pH is 1 something more.
Right,
So
okay.
this is really helpful.
So, I think the question was raised, and this is absolutely critical to a case like this, is why has this gone so badly wrong when you have been doing all the right things according to the guidelines? And what this tells us straight away is one huge deficiency of these and other guidelines. That is, they don't really address the question of the patient who will not comply with treatment. These guidelines presume that what you tell the patient to do will be done. And here, it's obvious that the patient has not done it. The patient clearly has not